Welcome, Dr. Bean.
Thank you for having me.
I am so excited about this conversation. It is definitely a hot topic and one that I think a lot of people shy away from. And that is why I love that you do not. So before we dive into this conversation, how did you get into this work?
Yes, so vaccines is a large part of my practice, and it has been a journey to get to this point to have vaccines as such a big part of my practice. So it really started when I started practicing in Singapore, and this was in it was about 2014. I'd just become a new mom, and within Singapore, there are mandated vaccines. So having just had a baby, a lot of people, started to come see me for pediatric care. And I had a couple cases where I had a family come in where they had vaccinated their child, and there were some concerns post-vaccines. They had, within Singapore, you can see specialists as, within 2 or 3 days. So they had been seen their GP, they had seen a couple different specialists, and to no avail was there any answers for them in terms of what was going on. So I was kind of the last kid on the block. They came to me, and it wasn't about, was it a vaccine or not? It was, how are we going to move forward and help my child now? And from a naturopathic alternative perspective, what are we going to do to help the body? Mm-hmm. So I was a new graduate and a new mother. So as a result of that, I had sympathy, great sympathy. And as a new graduate, you think you can do anything. And I didn't know what I was dealing with. I had no idea. I mean, as a naturopathic doctor, we are trained in terms of the vaccine side, the same as medical doctors are. You are trained about the infections that which you are vaccinated against and the schedule, and that's it. So that's what is taught within our pediatric lectures. So I had no idea what I was dealing with. I didn't understand the product. I didn't understand then what I would use and why I would use it, because I didn't understand the product. And so it happened to me twice, having worked there for a year, and I was embarrassed that I did not have an answer. And so as a result of that, I really started diving into understanding what vaccination is. And we moved back from Singapore now almost 5 years ago. So when I came home, I took the immunization certificate here in British Columbia to be able to administer vaccines to my patients. Okay. And I did that so that I would have more understanding about the vaccine. And with that, if there was at all a adverse reaction, I would know how to support the body. Now, I have not had any adverse reactions in my office, and that may be because of how I'm preparing the children. We have great dialogue around this, and so the parents are vigilant, and we haven't had any issues. So, I support parents. They come in, they want to, first off, lots of questions. And so we go through all of those questions that they have. They want to vaccinate, so we're going to vaccinate. Or I have people who have to vaccinate, and so I support them that way as well. I've had, teenagers come in. I've had one 18-year-old unvaccinated who was going to New York for a full ride hockey scholarship. And so he had to have his vaccines updated. So it was either you get vaccinated or you don't.
And you can vaccinate children over the age of 5, is it?
Yeah. So kindergarten, so usually, you have to do your kindergarten shots between 4 and 5 years of age. And so I'm the same in terms of pharmacists here in British Columbia that can administer vaccines as well. We're in the same scope. So if it changes, then it would change for both pharmacists and naturopathic doctors in terms of timing.
Mhm.
But so yeah, for right now, it's just for 5 years and older. So I have a lot of families though that come in that have a lot of questions. And through this journey of vaccines, I have wanted to create a safe place for people to come to ask these questions. Vaccine optimization to me is having the place to ask questions, to have a dialogue, and to optimize the experience, to then optimize the body for better vaccine efficacy as well. And because there's lots of variables that are occurring here in terms of people with different genetic makeup that may not respond as well, and create more robust antibodies, an immune system that doesn't create robust antibodies. And so having that dialogue with parents, so then they understand why we're going to be doing certain things, or they've decided to delay, so then which ones will we start with and why. So I have a lot of different scenarios that have come to my attention. And so I've tried to put together sort of a standard of care with this. But I have colleagues that ask me, do you have an alternative schedule? Do you have handouts? And I have absolutely nothing. I have no handouts. I have no alternative schedule, because every single person is unique, and it would be a disservice to create an alternative schedule for somebody anyways,
Right.
because what is your situation? Where do you live in the world? There's different schedules around the world. From province to province, it's different. From state to state, it's different. Singapore has, at birth, they do BCG and Hep B. So it's globally it's different, and even within the same country, it's different. So it's unnecessary to create for myself some sort of alternative schedule. So I do not, and each
And
family is treated uniquely.
maybe we can touch on that. Why are schedules so different? Even
Mm,
if we're vaccinating against the same diseases or
yeah.
illnesses, why do they vary? Even within, state lines or provincial lines, it's an imaginary
Yeah.
political boundary.
You
So
know,
why?
I don't actually have a good answer as to why that is. It's going to be based on stats. It's going to be based on, if not risk profiles. So, with hepatitis B, which is primarily contracted sexually or through IV, in British Columbia, it can be due to the higher rates of hepatitis B in the moms, due to if there's more drug use, and having several sexual partners, versus perhaps compared to other provinces. However, I don't think that BC has more of that. Maybe it does. And so then versus Saskatchewan, versus Ontario, but I don't foresee that BC has more of that than Ontario. So it's going to be at the provincial level of that decision making with public health. And then they'll make those decisions. Alberta changed from having hepatitis B in grade school to now they put it in the infant schedule at 2, 4, and 6, and they just changed that a year ago.
Hmm.
So within 2019, they changed that early. So it's following trends. It's following, because every year the province should come together and see what are the trends, the stats. Do we need to change based on what's occurring, and then go from there. And if those aren't changing, then they don't change the schedule.
And I
But
think
yeah,
that's what makes the issue so tricky for people, is that, that this landscape is ever changing.
yeah.
So I think what would be really helpful is to kind of go back to basics and give people a kind of general understanding of what they're doing and how they work. So can we start kind of at ground zero and
Mm.
at a high level, because I know you give very detailed lectures on this, but how do vaccines work?
Yes. So the idea is you have a vaccine which contains the antigen. So an antigen, measles antigen, pertussis antigen, because in the environment, you would contract the antigen through, the mouth, you breathe it in. So what we're doing with a vaccine is putting in the antigen. Typically it'll be dead, or we'll do live vaccines, which are attenuated, and administer them, typically through the arm, if not through the mouth. And then after that is the body will see that antigen and take it, the immune system will be activated, take it to certain cells to present it, and those cells will say, that's pertussis. Let's create an antibody to that. So then your own body will be creating antibodies to that. And so then when you see, for example, pertussis in your environment, someone's coughed on you and you receive that antigen naturally, you're already primed with the antibody to neutralize the antigen. They kind of a lock key mechanism, they come together, and then it doesn't have ability to then manifest into, a cold and manifest into a deep cough, and then keep going as to how some of these infections, their endpoints of these infections can be pretty bad for people, from really intense earaches to meningitis. So loss of eyesight. So this is the prevention. The vaccine is used as a preventative mechanism where you can make the antibody. So then when you do see the antigen in the environment, you're already ready to handle that and deal with that. So that's essentially what vaccines are created for. We either obtain immunity via naturally or immunity via a vaccine. So we're mimicking vaccine-induced immunity is to create the antibody essentially so that you can, when you see it in the environment, you can deal with it much more rapidly, because it takes time to make the antibody. From a vaccine, it can take about 8 days to make an antibody from that vaccine. So then same with, might be a little bit faster, but the same if you were to contract it naturally, because it has to go through a series of events. The immune system is incredibly complicated, but brilliant. It is, there's so many different players involved to create that antibody, and the communication that happens within the immune system. So, it's very interesting once you start getting into it. It's clearly an area that I think I would have liked to have focused on, is technology, but trying to learn as I go. So there's new things that are being developed. Even today, there's new things that have been discovered in terms of the immune system, which is so fascinating to know that we are not at the end of understanding how our immune system works and the players that are involved and the different players that are involved. It is this huge orchestra of things that happen. And, when you get blood work done, there'll be different names of immune cells within your blood work. And so they're each involved in different things. So it's nice to see where you're at, even at a baseline. Can you handle infections very well? Can you make antibodies really well? And you can check and see if you can. And, I do that with my patients to see, well, what is baseline? Are you capable? And then even if you have contracted the infection, why don't we see if you have immunity to that, which is called titers or titers, as some people say. So you can do that with your naturopathic doctor or your medical doctor to know, what's my immune status? And when we're pregnant, we do that. We check for rubella and we check for hepatitis B when we're pregnant. So then even with my young female patients, is like, well, if you think you're going to get pregnant, why don't we check this first to see if you have immunity, because it's too late when you are pregnant, and you cannot get a vaccine when you're pregnant for these live viral vaccines. You need to wait until the baby is born. So it can be a good proactive thing to do with your patients, or for you yourself if you're thinking about it, or to see if you created that immune status.
Yeah, I remember discovering that I was no longer whatever it was immune and needed to go get my booster
Mm.
after my baby was born.
Yep.
And it's interesting because when I heard you speak about getting titers done during the vaccination process or beforehand, it makes so much sense, but it's not part of the common vaccination delivery mechanism.
Mm-mm.
So if you were to go to your GP and say, hey, if we're going to do this vaccine now, can we check titers in 10 days or
Right.
whatever it might be, is that something that they would
Would
do?
offer or
Yeah.
be inclined to doing. So it is not common. Now, first off, in terms of titer testing, I would not do it any earlier than the age of 1. I would be over the age of 1 of checking titers if we were to do that. Typically, when I'm checking titers on patients, the youngest I will do when they're 4 or 5 years old, because we're getting ready to do booster shots. So here in British Columbia, then when you're age 4 or 5, your kindergarten shots include your MMR with chickenpox and then a DTaP vaccine. So what you can check for titers includes measles, mumps, rubella, chickenpox, hepatitis B are what you can check.
Because they're
And
live.
because they're
Got it.
live, and although hepatitis B is not, it is something that we can check, but routinely we cannot check pertussis, diphtheria, tetanus. You can, if you've just done the DTaP vaccine, you can check diphtheria and tetanus. But pertussis, no. Pneumococcal, no. Haemophilus influenza type B, no. So you can't know if you have immunity to those things, which is unfortunate.
Okay.
But I do check the live viral ones on kiddos. And I've been doing that more after we have done the MMR vaccine, because it's more the common ones that I do, to see if the body has created immunity to those. And I'm keeping that data for myself just to see even who is seroconverting and whom has responded to that vaccine. I was able to check the tetanus diphtheria of a child that their first vaccine they'd ever did was a Tdap vaccine, and the child had created immunity towards tetanus with that one shot. So that was interesting to know, and that was great for the family to know if they needed to do more or not, to have that information. It's not offered regularly, and most likely because it is a blood draw. So, versus a vaccine is quick in the arm, versus a blood draw, it's a little bit more, can be traumatizing for a child. It is more painful. So that aspect, we have to ship the blood work off, paperwork, and so forth. But if, an older child, we'll talk about it. And I've lots of children who champions through checking their titers, and they've been great through that. I've a couple of different things that I do to help reduce pain, and put a Netflix video on, and before they know it, it's over. And
Yes.
they don't even realize that it just happened. So
So
there's,
that's something that you could do before, like a booster, say, for an older child, if you want to go through that. But if it shows that the antigens are still there, does that mean that there's no point in doing the booster?
right, because
Okay.
the paperwork will say immunity from vaccination or through the environment,
Okay.
so through natural, and it'll say that on the paperwork. So we have achieved the point, we've achieved immunity, because the point of having a vaccine is to achieve immunity to that infection. And if you've achieved it, your job is done. And so we don't necessarily need to do a vaccine, because now we have that information and it's on paperwork. And it's nice to have that information to know if you do or don't. Now, of course, the caveat is we can have false negatives with titer testing, meaning you might have immunity, but the lab didn't detect it. And it says that that you do not, but you may have. So there is that level of knowing, although the blood work says you don't, you might. So I can't use, no test can you use
Sure.
as 100% accurate. But it is something that's a tool that is there that we can use. So I've been trying to use that more and more, and I encourage people to use it, because I think it's something we do have at our fingertips to know what is the immunity of our community. let's check. So a lot of kiddos, if they're going to about to do their boosters, then we check. And even parents, a lot of adults have not done an MMR vaccine for 10 or 20 years. So let's check. And, I checked mine about 6 months ago, and I have immunity to everything. So it's a good tool to know, and perhaps in the future we'll have more tighter testing availability to different infections to know if you actually do indeed have immunity to that
So
particular infection.
so the booster shot schedule then is based on kind of a general average or assumption that public health has made to try to ensure that the majority of the population who is getting vaccinated maintains their
Exactly.
immunity then? Okay.
Because it's understood that the antibodies that are created via vaccine-induced immunity wane. And so their versus natural immunity does last longer, because it is a different route. When you breathe an antigen in, you've got the immune system of the gut to now deal with that, and then that slips through, and then systemically, and then we've got different players involved, and then continuation of those players involved due to contracting it naturally. Vaccine induced skips a couple parts, and you create antibodies, but they wane with the measles MMR. With measles of MMR vaccine, it's about 6 to 10 years.
Okay.
And so that's where we check and see if you have created, where if you were to contract measles naturally, it can be 20 or plus years that you maintain immunity to that.
Okay.
Yeah.
So that's kind of how vaccines work and what they do. A lot of the concern around vaccines or people who are starting to ask questions are around the other ingredients, not necessarily the virus component. So can you talk a little bit about what vaccines are made of and
Mhm.
some of the things that we should know about
Sure.
with these ingredients?
Sure. And so antigens will be one part. Vaccines have reduced numbers of antigens as well, because there was concern even of the amount of antigens. And when you do contract an infection naturally, you do take in much more higher concentration of the antigen when breathed in, when you're exposed to it. Now, in terms of vaccines, what's in them, there are now, this is where I ask patients to download the vaccine insert to read, because those ingredients will be on it. On my website, I have created, there's a vaccine component just on the homepage. If you click on that, then I've uploaded all of the Canadian vaccine inserts. You can click on it, you can read, because vaccine insert. And then so you can go to my website then to download all the vaccine inserts. And so when you do that, they're about 8 pages, which is going to be different than public health created ones, which are about 1 page. They're a quick synopsis. But the vaccine insert will list those vaccine ingredients. So what you will see on these, depending on the vaccine, if we're looking at a live viral vaccine versus something that is not live. And the ones that are live do not contain adjuvants. So adjuvants are there to stimulate the immune system to respond to the antigen. And so live viral ones do not. The other vaccines do. And so what that adjuvant typically will be is aluminum. And so you will see that on your vaccine insert. Now, lectures that I give on vaccines, I go into great detail of aluminum specifically, because I do, and coming from my journey with vaccines is I want to understand how this product works. And if there's an adverse reaction, why?
Mm-hmm.
And if there was, how do I help the person? So versus what do you choose to use with somebody, and why are you choosing that? So with
And what would an
aluminum,
adverse reaction look like, just so that we're
yeah. So
clear on that?
typically they're going to be mild. So there's mild, moderate, and severe. Now, having trained under the BC CDC, so British Columbia Center of Disease Control, there is an adverse reaction reporting system that's involved. And with that, there's a 3-page table format of what the adverse reactions possibly could be. And they're time sensitive. So either 0 to 2 days, 0 to 7 days, or 0 to 40 days, depending on live viral vaccines, they're usually 0 to 30 or 0 to 40 days. And they will list what those are, not in mild, moderate, severe, but they will list what they could be. So if you get the MMR vaccine, for example, maybe you have developed measles, or maybe you developed parotitis, so your parotid gland is inflamed. And so they do list even, and they put them in categories of neurological to, derm, so skin reactions. So they do list them that way.
So these are fairly short term, like immediate quote unquote,
Sure.
but result like effects that you would
reactions.
see pretty soon
You'd see
after
them
the
pretty
shot.
quickly.
Okay.
Exactly. And some of them, fever is going to be incredibly common, and makes sense that you'd have a fever as well, because you're asking the immune system to respond
Right.
to an antigen, or mounting an immune response, and therefore fever. And I'm going to get into Tylenol in a minute, responding to that.
Okay.
But so with ingredients in vaccines, so adjuvants are going to be one thing, which is a big part of what I lecture in my lectures, because we need to understand aluminum in vaccines is different than what's in food. And that's very critically important to understand, because in food, it doesn't act as an adjuvant at all. So we need to make sure we understand the difference between.
And
Other
is the
things,
form in vaccines, what is the biggest concern around it, or is there one?
well, so the form then within vaccines is it acts as an adjuvant. The difference then is that it will turn into water soluble, so your body can remove it. However, it has nanoparticles that are non-water soluble. So, but those are highly antigenic. So that's what makes it unique, is that those particles will bind to the antigen, so that stimulates the immune system to then respond to that antigen, which was just injected in your arm, versus the antigen just sort of floats away, and there's no point in doing what you just did. So
Okay.
the aluminum then, as a result of its form, and it's a nanoparticle, then binds to the antigen, because it's very tiny, to then so the immune system can respond. And then the immune system then will engulf that antigen, which is bound to aluminum, and then that immune cell, be it a macrophage or a dendritic cell, will move around and expose it to your B and T cells within your lymphoid tissue. So then, yes, then the aluminum is moving around within these systems as a result. So, this is where, discovering things, novel things that will help pull that aluminum out afterwards. So we'd like to remove that, because
Yes.
this form of aluminum is not natural to the human body. It is not something that the body needs or requires for a physiological function. It is part of creating that immune response, so the body will respond. And then we have this that we want to get rid and move out of the body, because typically you're going to do 2, 4, 6 months vaccines for getting this exposure. So let's pull that out as we can, as we carry on.
Okay.
Because there's high level understanding of what aluminum has the capability of doing in terms of physiology and neurologically over time. So it would be a good idea to help pull that out in due time. So that's where the level is a practitioner. We need to understand at that point, because then what what you can do in order to help the body pull that out, knowing that it doesn't pose any positive necessary aspects for the body at all. I mean, I'm sure you talk about aluminum foil, and let's avoid aluminum foil. And what's interesting about what we eat that contains aluminum, you only absorb about 0.1 to 0.3% of that aluminum. But over time, if you're doing something every single day, it's getting in, and then it can accumulate. As the accumulation of that we can hit a threshold where your body might not really like that. And so we need to work on either reduction of the exposure or working on pulling that out. And what are those things? Well, that's what your practitioner will speak to you about.
Okay.
So aluminum would be the top one, because how it makes the immune system respond. It gets
And
it
it's in
geared
just
up.
about everything. All of the, I mean,
Sorry,
look at, it's in just about all of the vaccinations.
the aluminum.
Yeah.
All of them, yes, most all of them. Some of them use a tetanus toxoid as an adjuvant, which might contain a little bit of aluminum within that. So some of them aren't frank, have aluminum in them. They'll use a different adjuvant, which may have bound within that a little bit of aluminum, but it'll be less than, and it may not be listed as a result. Like Haemophilus influenza type B, Hib on its own does not have aluminum in it. So it uses a different adjuvant, but that adjuvant might have a little bit of aluminum in it though.
Okay.
But much less than other ones. So that's a single one that is available to do. Next, they use things like polysorbate 80 will be in there. There is formaldehyde.
And that's a
in there.
preservative.
Preservative, yeah.
Mercury is one that comes up a lot on people's
Yeah.
concern list.
Yeah, certainly. So thimerosal will be used, but it's used in multi-vial flu shots. And there is a DT vaccine, not a TD, but a diphtheria tetanus vaccine that's used in the United States, which Dr. Paul Offit has on one of his papers talking about the amount of thimerosal, and it is similar to the multi-flu shot. So this is again where we're looking at some of the vaccines either we don't have in Canada. So all of ours in Canada, as far to my knowledge, have very little, if no, thimerosal. And what's interesting about thimerosal, which is ethyl mercury can actually be methylated into methylmercury, which is what we find in fish. So it takes time for that to occur, but ethyl mercury does methylate. Be it that's good or not good, but having that awareness and understanding of thimerosal, I think, is good for us to be at that level of understanding.
And can it do that in the body?
Yes, so that it would be methylated within the body. Within the body. And I think it's over maybe about a 7-day period, if not longer, it takes for that to happen. And then knowing what you know to get methylmercury mobilized and supported out of the body, then you can do that too. And this is where bodily functions are back to the basics. You're pooping, good liver function, bile production, urination, you're drinking lots of water, sleep. These things in turn are basics to help mobilize and remove these things. The body can handle so much, but it can handle. It's just there are perhaps some genetic variability in people, epigenetics, but then the environment that they're in, exposure to other things, just essentially fills the bucket. And then
that's the analogy I give all the time.
Absolutely. Yeah.
Right. So,
absolutely.
So if you're going into a vaccination, it's important to understand. And I think really going back to the basics, like you said, and making sure that everyone is, feeling good and healthy, and you're kind of ramping up. If you do choose to vaccinate, doing those things can help with the aspects that you might not love about vaccines, right?
Right. I mean, it's even preparing people for surgery, to dental work, to, there is something that you're going to be doing to your body. And if you're at a tipping point, well, no matter what, we should be optimizing you anyways, but you're going to be doing something that could be inflammatory, that's adding to the bucket. Let's drain it a little bit and then move forward. So it's just the tipping point. But yeah, so those are within so aluminum, we talked about polysorbate 80, thimerosal, formaldehyde will be in there, a little bit of formaldehyde. Antibiotics will be used just to ensure if there's any exposure to anything else to kill within that vial. And And then you're looking for different names in terms of the cell lines that are used. So some of the vaccines do use aborted fetal tissue to grow that antigen on, because that infection would not affect an animal. So therefore, we're using human cell lines to grow the antigen on, which the cell is not in the vaccine at all. That's purified out, and then you're left with the antigen. Now has been discovery of DNA and RNA fragments, which are, I don't know how big those are, not very big. So
Yeah.
you can't filter them out. They're still within the vaccine. Cells you can certainly filter out, but these DNA and RNA fragments you cannot. So when you see MRC5, WI38 on the vaccine insert, typically it'll say human diploid lung cell or whatnot. They'll use the name, but they might, if they drop the descriptive name, then they'll have sort of the acronym or the number name. So WI38, then you know that would have been from an aborted fetal tissue, which is not there isn't fresh aborted fetal tissue that's used over and over and over again. It's the same line that's used over and over and over again. Because some people think that aborted fetuses are used over and over and over, and they are not. If there's a new line that is being discovered, which there is coming out of China, then you are using new aborted fetuses in order to do that. So people wonder why they're used. This is why, because these infections don't affect animals. Those that can affect animals, then they'll be using, cow, the caterpillar's been used, dog has been used, monkey kidney cells have been used. So different animal cell lines have been used to grow the antigen on. It would be great to see if we could see that in the future, these antigens are grown on yeast.
Mm-hmm.
That would be the level that manufacturers should get to, and then just using yeast and that's it. But I think that clearly is probably very tricky. The meningococcal vaccine, the quadrivalent, as I believe, does use yeast. So it's as its cell line to grow. So be great if we could get to that point of just using yeast cells.
Yeah. All right. So those are some of the kind of core ingredients that are going to be in them. Again, I'll link to your website where you have the information on the inserts and all that so that folks can check those out. And we've touched a little bit on this kind of woven throughout the conversation a bit, but what kind of factors should go into the conversation and ultimately the decision that families have around what to vaccinate for and also when to do it?
So vaccination in Canada is by choice. So it's your decision to vaccinate or not. There is the recommended schedule for you that is put in place. And schedules, what's brilliant about schedules is that everyone knows what it is. So if you were to go into public health, you could see a different person every single time, but they know where you should be at a schedule. By making an alternative schedule, that's freaking convoluted and lost. And did we do that one? I mean, obviously, if you have it on your vaccine schedule that you did, no one should lose that, and we should know what's coming next. But this is why schedules are put in place, because it's easy to follow. But again, it is by choice if you are going to vaccinate or not here within Canada. What I go through with families is, what are your risks of contracting this infection, and what is the susceptibility or the health of your child or you, that if you were to contract the infection, would it be mild or could it be severe for you? Of course, there's no way of knowing, but we can understand if you're a sick person, immunocompromised person, on several different types of medications in themselves suppress the immune system to make you immunocompromised. So what's going on in your life, how is your health. And with children, we always talk about pregnancy history. We talk about how the labor went. Was it a C-section? Was it natural birth? Is your child breastfeeding or not? Formula fed or not? And so, because all of these play a role in the susceptibility for that child, that if they were to contract the infection, it could be mild or severe, potentially the risk of that. So we have that discussion, and and then we have the discussion of, do you understand these infections? Do you have any idea of their possibility, and of what they could take your body to? And a lot of people don't even know, like, I don't even know what I'm vaccinated against. I just know there's a bunch of stuff in a vaccine with a bunch of, measles, I guess, and that's it. Like, well, I want you to understand what you're vaccinating against as well. Get to know your infections, get to know your vaccine, and get to know your infections. So there you will always walk away having to do more reading, and understanding, but that's where I can push you and get to the level of, I know why I'm making the decision that which I'm making. I have a lot of patients that vaccinate. I have a lot of patients that come in already with the decision that they're not going to vaccinate, and knowing that I create a safe place to discuss. We will have a discussion around this. Medicine should never ever have any type of level of coercion within it, and you make that decision for yourself. And if the consequences are on you of your decision, not on me, it's on you of your decision, and I want you to make that decision based on the information that you have, the evidence that you have, the environment, and then you go forth with that. So the decision of when and what, I mean, it depends, who I'm talking to. I'm talking to a pregnant mom, or I'm talking to parents that just came in with a 5-year-old unvaccinated, and now they're in to now discuss of doing vaccines. I have a lot of parents that come in with their children. They can be 18 months, 2 years. A lot of times I've families come in, their kiddos are 5 and they're unvaccinated, and they have a lot of times stayed unvaccinated due to how they were treated in the beginning.
Right.
And this is a big part of why I do this, because there was a massive level of shaming that was going on. They went in to ask their pediatrician, their medical doctor, the public health nurse, just simple questions around vaccines. And I understand that in terms of the level of time is absolutely going to be different. I have a lot of time with people, and I don't have to rush someone out of my office within 5 minutes. I don't have to do that. And so, of course, if I need to rush you, then I'm going to stand up and let's go. I can't talk to you anymore. And being in the shoes of a medical doctor, pediatrician, I get that you only have so much time. Now, you have the decision of how you answer the question, or your tone of voice, or giving someone guidance of where to get more information from different websites that you provide. And so then we're having a discussion, we're discussing. And so versus if I'm getting angry with you or shaming with you, you're probably not going to come back to talk to me.
Yes.
So I don't create that environment. And it's due to hearing other people's experiences is why I do this, to allow, let's have a conversation. And so then a lot of families, they're on the fence, and they decide to vaccinate. And then which ones are we going to do? Because it's been so long, and my child is 5. So which one should we do, and which one should we start with? So that kind of conversation we start to have. So yeah, it's different for everybody in terms of, which ones and when, but even the discussion around infant immunity is a big discussion to have. And that's, I go to more great detail within my vaccine webinars, because I think we should have an understanding of how it works, because that plays a role in vaccine efficacy as well. And even if you have had vaccines when you were pregnant, particularly the Tdap, that affects the effectiveness of your infant's vaccine. So that's a conversation we need to start having, because the vaccine is given in pregnancy due to the fact that an infant can contract pertussis in its first 2 months of life, therefore have it in pregnancy, which you do create antibodies towards, which you do pass on to your baby for protection. But there's some interesting data around if they get a vaccine, then the efficacy decreases due to mama's antibodies. So these nuances that I have, knowing pregnancy and what she did, then I kind of know where to go in terms of our conversation for what's coming for the baby. So there's all these, this is where it is not a black and white conversation anymore. People really still hung up on that black and white conversation, but this is understanding that research and we do something, then we do research and realize, well, maybe that decision wasn't the best decision due to our research, but we need to do certain things in order to have something to research to then have an idea if that worked or that did not work.
Yeah.
So that's the beauty within science, is that it changes. And it's a good thing to stay on top of things so then we can make the best decision as a result of what that evidence is saying. So then, one needs to stay on top of this to know what is the best. And be it if mama did vaccines in pregnancy, that can change our conversation around for the baby. So this is, every situation is different. Every scenario is different. Where you live will be different. Your exposure to things will be different, and even your vaccine schedule will be different. So, even take Denmark, for example, they don't do the rotavirus Hep B at birth, and their MMR vaccine is at 15 months. So it's compared to the United States, compared to Canada. Singapore does the BCG vaccine at birth along with Hep B. United States does Hep B at birth. So there's different variabilities within the vaccine schedule. I do not know them all, but can quickly look online. You can get to know your vaccine schedule of where you live. And if I have a family that's moved from Saskatchewan to BC, their child does not have a Hep B vaccine and they're going into grade 6, they would be certainly eligible to have a hepatitis B vaccine. Versus my BC kids, we can check the Hep B status for them before they get into grade 6, and hey, you've got status. So, you don't need it, or maybe you do need it. And so this is where tightening things up along the vaccine scope, but of course, it takes time. And this is where I want to educate my parents to be also more aware of what they can do and what's out there, versus if it's black and white. Even black and white, we are going to miss things within that. And so this is understanding, this is why it's becoming a bigger part of my practice, so that I focus more on this subject to know those little things as well. Heck, I could watch something every single day, read something every single day just on vaccines. And I'm not a vaccine expert by any means. I'm just trying to get there. But that I wasn't taught in school. So now it's self-teach from textbooks, from immunologists, from vaccinologists, and trying to absorb as much as possible.
And piece it all together.
Yeah.
I know that road very well with
as you would. You feel like a lone wolf sometimes.
One of the strategies that I know comes up a lot, and people ask me all the time, I'm like, I don't know, not my field, is whether we should be considering spacing out vaccinations more, or if there are options to separate some of those. I think there's now a 7-in-1. It's all changed from when my kids were vaccinated even, but 7-in-1 versus 5-in-1, can you pull them out and do different things? Is that something that warrants a discussion?
So yes, so it depends where you live in terms of your options, because here in Canada, we do not, Canada has licensed the vaccines that which they have licensed. So I cannot get the DT vaccine, for example, for Canada. Or I can't even get just the DTaP 3-in-1 for Canada. We don't have that available. So knowing where you live means what you can have access to as well. So at 2, 4, and 6 here in British Columbia, it's going to be the 6-in-1. Now, within the 6-in-1, you can pull out hepatitis B, which other provinces do. They do a 5-in-1. Now we also have an option to do the 4-in-1. And when you do the 4-in-1, you pull out Hib, Haemophilus influenza type B. Hib can be a vaccine that's on its own. So that can be a one shot. Now, separating vaccines or making them, slicing them up means more injections in the arm. So this is why doing a combo vaccine means you're just one poke is what that means as a result of that. But then when you are when you're reducing it, then yes, you have, 4-in-1 means 4 different infections the body's going to respond to. And some people really do want to pull out the Hep B. They want that later, closer to a time when they would be more sexually active, to do that in terms of for more efficacy for that as well. So it's available, and so Hep B is available on its own too. So then also dialing that back of knowing who's in your household. Could anyone in your household possibly have hepatitis B active infection? Could they? Because then that does put your child at risk if you have an active Hep B carrier in your house. So that's where the decision of doing it is if you do have such a person in your house. So that's that option there. MMR vaccine cannot be separated here within Canada or the United States. However, there are countries that do offer that. Japan makes their own measles vaccine. France has an MR vaccine. So I have supported a family that was moving from one country to France. So then they knew, okay, well, there's a different option to the country that which I'm moving to. So they're, working with international people of where you are and where you're going to, what's available there, depending on what you want. So that's where the plan can be made there. When you're separating vaccines, then you can have less aluminum exposure all at that one time as a result. Hepatitis B vaccine does have 250 micrograms of aluminum in it. So if you pull that out, then that would be 250 less. So then you could get that exposure later. So that in smaller increments as a result versus larger increments.
Which might be easier then to work with the protocol with your practitioner to pull that out, I guess would be the idea, right?
Would be the idea. And, because this is where I do a pre and post vaccine protocol for kiddos,
right?
And supporting their body through that process. And this is maybe why I haven't been having adverse reactions in my kiddos, and more so be it longer fever, lethargy, and maybe even got sick. And then having that discussion of, I would like a healthy child going into the next vaccine versus a sick child. I want a stronger innate immune system when they're going in versus if you have a current infection, what does that say about the outcome of the vaccine efficacy? How do we know that if, yes, you could do the vaccine, certainly you can do the vaccine, but I'm about vaccine optimization. I'm about efficacy. If you're sick, could that potentially decrease the body's ability to mount a better, more robust reaction to the vaccine to create those antibodies? So if there's any level of other things going on, then this is where, well, let's make the child healthy and robust in terms of no infection currently or proposed infection before we do that vaccine.
Yeah.
And then in addition to that, the conversation around Tylenol comes up because it's still suggested to do Tylenol pre-vaccine and then doing Tylenol post-vaccine.
Oh.
And I disagree with using Tylenol at all around vaccines, and for 2 different reasons. First reason is it's Tylenol has been shown to reduce the immunogenicity of the vaccine. Tylenol has shown to reduce the vaccine efficacy. So I don't agree using it. In addition, Tylenol will wipe the body of glutathione. For those that understand or don't understand glutathione is incredibly important as an antioxidant and for phase 2 detoxification. Also acts as a gentle chelator, bind to metals. So regardless, kiddos are going to get glutathione because glutathione is also helpful in terms of the immune system. So kiddos will get glutathione within my vaccine protocol
I've
too.
been talking about glutathione a lot these days.
Oh, right on. Yes,
Yeah.
it's wonderful.
Yeah.
I mean, you can nebulize it, smoke, nebulize it and support people that way. It can be helpful. You can do injectable, you can do oral. With kiddos is just oral. But even understanding the building blocks of glutathione too, and
And do
going
you do
backwards.
glutathione or do you do
NAC?
N-acetylcysteine?
No.
Yeah.
So I just do glutathione, do liposomal glutathione is what we'll do for the kiddos. And, it's got a bit of a funky taste. It is a sulfur product. So we try to, either we can do something alongside that to sort of downplay the taste. But there's some, Designs for Health has a product, Quicksilver. I really like Quicksilver for their liposomal form. And it's not too bad. Research Nutritionals is another one. They have their Tri-Fortify watermelon flavor one. My kiddos will eat that, to their heart's content. They love it. So you never know the palate of your kid. And they will.
My kids started swallowing magnesium capsules.
Oh, right
He's
on.
5.5 and they're not small. And he was like, yeah, I'll try it. And he
Awesome.
did it. So don't assume
Mm-hmm.
that your kids can't or won't do something is the
No,
point
absolutely.
there.
Absolutely.
So,
I mean, my kids will steal my big fish oils and like chew on it and just eat it. And literally will go into my pill pack and like flip, take out. And I'm like, where are my fish oils? The kids just stole my fish oils. I mean, it's not a bad problem, but anyways, it's
go
just
figure.
never know. And
Yeah.
then heck, there's lots of vegetables that they don't like, but they'll take glutathione. So you never know. I mean,
Yes.
of course, the unfortunate part is going to be purchasing something that which they won't do anymore. You don't know, and it's hard to get samples. But even the Tri-Fortify one, you can get little sachets and you can squeeze it into your mouth. And if they don't like it, well, hey, we can sell it to someone because you just use one packet at a time. But yeah, glutathione, Tylenol, if kiddos are having a fever, this is where we have a conversation of other things we can do for a fever. A fever is not something to be ultimately afraid of.
Yes.
Fever is your body's, one of your body's best defense mechanisms. Heat kills. It's not something that you want to suppress. It is not. Even put aside vaccines for a minute. I mean, fever on its own, I really allow for my kids to pursue that fever. Now you're monitoring what the fever is. I have intervened with my kiddos if it's way too high. But it's not, I don't just jump on it and let's suppress this fever. No. So there's other things you can do, and that's where you talk to your healthcare provider about what those things are, and to not just jump to using Tylenol without even symptoms. Give it to them before, give it to them after. Do not do that. So that's a big part. And there's evidence around the issues with Tylenol and vaccines. So this is where, nope, I'm not. Say no to Tylenol, say no to Panadol. Don't use it. But if your child has a fever, then speak to your practitioner what you would do instead. Yeah.
So along the same lines of kind of separating out or modifying the schedule a little bit, there are some things that we vaccinate for now that weren't around when you and I were at that age, let's say. So rotavirus and chicken pox come up, have been asked a fair bit. I asked in my client community if anyone had any specific questions, and these are ones that came up. So the idea is kind of, we grew up with it. It seems pretty mild. Rotavirus, if your kid's not in daycare or whatever, is it really that important? And chicken pox, how necessary are they?
Well, so chicken pox was formulated in terms of ensuring that children wouldn't have to stay home if they contracted it. Because if they had to stay home, then parents would be staying home and missing a good week, typically a week's worth or 3 days of work. So the CDC had on their website that it was formulated in terms of helping families so that parents wouldn't have to miss work because their child was most likely going to catch it and then
For real?
would have to deal with it. Yes.
Seriously?
Yes.
Well,
So
that
they
just
don't
makes
have
me
it on the
mad.
website anymore. They've taken that down, but that is the original reason chickenpox was formulated. The vaccine was formulated. And as a result, we do see less chickenpox as a result. Now,
I wanted my kids to get chick. I'm one of those crazy people. So
you're
I'm
not
probably going to get hate mail for this because people slay me for
crazy.
all sorts of things. But my kids they have most of their vaccinations.
Mhm.
All of them, I think they're caught up now. But chicken pox was one. Like I actually wanted to find somebody that they could lick and get the
Sure,
chicken
sure.
pox. That didn't happen because nobody's getting it anymore. And so that
Right.
natural immunity now has kind of been wiped out with this, right?
Yeah. And so there were countries, well, the UK had opted out of adding chickenpox to their childhood vaccine schedule due to having, you know, the thought process of if we do use chickenpox in our vaccine schedule, that will mean that our adult population will not be re-exposed and their natural immunity will wane. And that might increase rates of shingles as a result. So shingles is a reactivation of varicella. Because varicella, when you contract it, it does, stays in the body forever, hangs out within the nervous system. So then when you get shingles outbreak on a body, it's very painful blister. It follows dermatomes. So you'll usually get a line of it because it's following a dermatome. So now we have a shingles vaccine. So a shingles vaccine is dead varicella. It's not a live viral vaccine like the chickenpox vaccine. So you're going to be giving a shingles vaccine to the elderly population because they're not going to be re-exposed to it anymore, be it as they get older. So typically your 5-year-old catches it, re-inoculates you as an adult. You carry on for another 20 or 30 years. Grandbabies are around. They get chickenpox, re-inoculated at that point, but you already have you had it naturally and then you got re-inoculated by it as an adult. So your antibody level should be high enough at that point that you can handle the exposure. But now those antibody numbers are waning as a result. And then when you do see it, potentially then shingles could arise, and there is an uptick of shingles, thus shingles vaccine. So that was where the UK was like, no, we hypothesized that we might have an uptick of shingles. So they opted out. They did not add it to their childhood schedule, vaccine schedule. It's available to do, but a lot of kiddos still within UK contract chickenpox naturally. I had a 10-month-old patient whom we believe contracted chickenpox from a previously just recently vaccinated child to chickenpox. So the ability for the vaccine to shed is there. There are case reports of it shedding. And I got to the child too late, or I swabbed, I picked, I sent off chickenpox to a sample to the BCCDC and came back negative. So I was too late because it was crusting at that point. Had I been able to get there a bit earlier, then I might have been able to got a positive. But the child was diagnosed with chickenpox by the GP before I was able to get a sample anyways. But what we're going to do is we will check the antibodies to chickenpox in a year or so and see if was indeed chickenpox they were exposed to. Because if you are exposed to chickenpox and diagnosed before the age of 1, you do not need a chickenpox vaccine as stated by the BCCDC. So this child, therefore, for 12 months does not need a chickenpox vaccine, having been diagnosed with chickenpox at age of 10 months of age. Okay. So there is that there. Which I think people might not be aware of. Public health might forget. You might forget to say that, your child had chickenpox. So this is where I remind parents of if they've been exposed, this is something that they do not need as stated by the BCCDC. Right. So because either you get stuff naturally or you get it through vaccine. There's only 2 ways of creating immunity, and those are the 2 ways. And so if you've been exposed to it knowingly, you don't need to. Now it's a single vaccine. Now let's say you were exposed to measles. Well, you weren't exposed to mumps and rubella, and it's a trio vaccine. So yes, maybe you had measles, but no, you didn't have mumps and rubella. So then you're doing the MMR vaccine.
Right.
Um,
And what
but
about
yeah, I mean,
rotavirus? That's another one.
and then rotavirus. So yeah, it's fecal oral. So typically this is where we see it at daycare, where, you know, you're someone's cleaning your child after they've had a bowel movement, and it could be on their hands. So then when they go and change the next baby and they're touching the baby's hands, the baby will hand to mouth. So that's fecal oral. That's how they're contracting it. And then that will create diarrhea in itself. And diarrhea can lead to dehydration. So that is where we want to avoid that. Now, infants in North America do not die of dysentery. We don't die from dehydration due to diarrhea. It does not happen here because we do have that capability to prevent that from happening via, you know, doing a saline drip. Now, the point also with vaccines is, in public health eye, is to reduce reasons of needing to go to the hospital. So if we're going to do a vaccine, then these things would be why the infant would not, or the person would not need to come in because you had the vaccine. So it's trying to reduce hospital visits as well.
So do you know if they saw an uptick then in
Rotavirus?
rotavirus?
That I don't
Yeah.
know since the vaccine came. That I
Or
don't
is
know.
that why the vaccine was introduced? Like
So
I'm always
yes,
curious.
yeah,
Yeah.
of course. So you have rates and cases of certain infections, and then you make a vaccine for that because of so many cases. Haemophilus influenza type B, the rates of glottitis have decreased since the inception of the vaccine. It also can cause ear infections, otitis media, but I don't think that cases of otitis media have declined since the vaccine, but epiglottitis has. So there are these trends. So the efficacy of vaccines is based on trends of that infection. The rates go down, and antibodies were made from the vaccine. Those two components equal vaccine efficacy is
Okay.
what it's based on. So yeah.
I had another question from a mom. If there is a reaction after having a vaccine, like a fever or one of the typical ones, does that mean they shouldn't get more?
Right.
Or should there be
Right.
some other kind of look at what should
Right.
happen?
So
Or eczema, that
in
was another, like
right.
fever, eczema, those sorts of reactions.
So fever would not constitute you of your child from not having another vaccine. It would be something to be aware of, though, for the next vaccine, but a fever would not. So this is where I ensure that my parents know what they're looking for, because you need to have that conversation with the administering physician or public health right away if there was what you think is more than an adverse reaction, and based on that table that has been created. So this is where we need to be more diligent. BC CDC, each country wants you to report if there was a problem. They want you to report it.
Well, that's the only way they know if
That's
there is
right.
an issue,
The
right? Yeah,
only
that's a
the
fair
way,
point.
because
But
if
nobody
there,
asks. It's not like the doctor's office calls you and says,
of course,
hey, did you have XYZ? So it really is up to us
up to you.
to provide that information.
Yeah, because it goes in Canada, goes to a federal level, and every year there is an annual meeting to look at trends. This is how for rotavirus was pulled due to intussusception. There was increased uptick of intussusception. This is essentially where you've got your bowels go into each other. Incredibly painful. It is not a good scenario. So they detected that because of reporting. The DTaP, the wholesale DTaP vaccine, was pulled due to adverse reactions. And then the acellular form was created. So we rely, the vaccine manufacturers or public health, they rely on this information that comes from the public because this is phase 4. So in terms of vaccine safety, efficacy goes through clinical trials, phase 1, 2, and 3. And at 3, those vaccines are licensed. Now, phase 4, we're not done yet completely in terms of now it's out in the population. How is the population handling the vaccine? Because you can only, you only use so many people, and the people that which are used within clinical trials are healthy people.
Mm-hmm.
So now we're at more of a reality state of how is the vaccine doing within the public. And now we have a lot of people that are using it. So we need feedback. We do need feedback so that if we do need to pull a certain lot, a certain vaccine, then yes, then they'll know to do that. But relying on us to give that to the physician then is to report it as well. So that's where you have that conversation with them. That's where you can get the paperwork for yourself as well and have that more detailed outcome. I think this is where I'm tightening up the details as well when it comes to, I know exactly how each of my patients are doing at any one time. I am asking for that feedback. And if there's no feedback, then there's nothing to report. So I've not ever had to report anything. And I'm, they're going to let me know as well, because they also feel safe to do that.
Yes.
So they absolutely will call the office right away. They'll email me right away. I had one child whom we did the MMR on, and later that day had a headache. Now, he was incredibly nervous in my office as well, even though I tried to make it fun and light. And I use this thing called a buzzy bee. And so we were doing all these things, and he's watching a video, but phobia of needles completely. So later that night, it had a headache, but it's like, well, the next day it was gone. It was just really amped up due to the sight of a needle. So it's very, very, very quick. Doing vaccines are incredibly quick. So this is where she called me and we chatted. I checked in again. I called her later in the day, and she's like, actually, no, he had a bath and he's doing okay. So, but yeah, I mean, I'm very hyper diligent and aware, and because I think so. It's a medical intervention. I think that we should treat it as such, and I think that parents should be able to have the liberty and know that it's okay to also be hyper vigilant and be able to have that conversation with whomever administered the vaccine as well. Because if I did not administer it, there's not a whole lot that I can do for you. I'm not the one reporting it because I'm not the one that administered it. So you have to go to the person that did do it to do that for you. Yeah.
And so reactions like that are kind of easy to see and correlate to the vaccine. I want to be aware of time, so we can keep this a little bit brief, but can we touch a little bit on the idea of vaccine injury and what that means, and what people should know about it, and what parents should do if they suspect their child has a more severe interaction?
So vaccine injury is a tough topic because your administering staff has to know what they're looking for, being open to having that dialogue if it's an injury or not. Now, here in British Columbia at Children's Hospital, there are 2 vaccine specialists that are there to handle things like this. So we do have in place experts within the vaccine space, medical doctors. And so I've referred to them a couple of times already. And then because that's all they do, that's all they know. And there have been vaccine, shall we call them exemptions, due to reactions here in British Columbia. So this is where our chart notes, my chart notes are very detailed because if they're ever needed, then that can be used, especially even for the vaccine specialists. So, vaccine injuries, those are going to be along the lines of something neurological as a result, but it has to be in a time frame, but it also has to be, having that conversation with administrating staff to be aware of what you're looking at and what you're dealing with. What was the health before the vaccine? This is why I also take detailed health notes, because when you go in to get a vaccine, it is unknown, or you're not having that detailed conversation pre-vaccine. It's just we're coming in to do the vaccine, and that's
Right.
it. Because there are adverse reactions listed even on the vaccine insert. So for you to be aware of what those are on the insert as well. Yes, they are proclaimed to be very rare. And I think the rarity is going to come because things aren't reported in a timely manner, are not discussed to report, to know a more detailed how rare they are or how common they are as a result, because we're not being as tight with this as possible. We're not doing as an excellent job as one could be. And that can be because it's a time crunch typically. But yeah, usually the vaccine injuries, because an injury means lifelong, or injury means months of that new symptom, will come as a neurological one. And those are listed on the table through the BC-CDC in terms of adverse reactions, which anyone can Google BC-CDC and adverse reactions. The United States has one as well. They have their adverse reaction table as well, which is also similarly based on time frame as well. So you got to know that there's a time frame. You have to know what you're looking for, and you also, having that information of pre-vaccine and history. I have a child that I didn't vaccinate them because they were 4 years of age, but I referred them to Children's. The child had had seizures pre-vaccine. The first vaccine they got, there was no seizure, but the second vaccine they got, there was a seizure post that. But the seizures were pre-vaccine too.
Right.
So there is potentially a susceptibility, but susceptibility to even perhaps contracting something naturally, or like head trauma, or maybe aggressive dental work that had to be done. And so this is so we can't just bank on the vaccine. Absolutely. This is why the health history is really important. Even you as a parent, what's going on with you? And mom and dad, of course, mom more so, but what happened during the pregnancy, what happened during the labor, all of these things are important to know in terms of how healthy and robust that body is, and what exposure did they have during the pregnancy. So all of that plays a role, because this medical intervention it is immunostimulant. It stimulates the immune system, and stimulating the immune system is inflammatory naturally or vaccine induced. So take COVID. COVID is incredible issues. Oh no, am I back? Okay, good. So COVID is very inflammatory in itself, very inflammatory. So this is why why certain demographics will have issues with COVID more so than other demographics, because if you go into it inflamed, add inflammation onto that, inflammation is not a good thing. Acutely, fine, if your body is able to handle that inflammation, and there are ways that which your body handles it. And that's why a lot of people will be on anti-inflammatories naturally, hopefully, to combat the inflammation. So vaccine-induced immunity, there's inflammation involved. Naturally acquired infections, there's inflammation involved. Surgeries are inflammatory. So there's all these things where, are you more susceptible to the inflammation? How are you going into this? What's your history? So this is all these little nuances to optimize the vaccine experience, be it verbally, optimization that way, but also physically of actually the administration of the vaccine. So I'm trying to, through conferences that I'm doing, to really to share this with physicians of how I do things. Be it my way is not the best way, but it's a different way, and I find that it's working. So maybe I'm creating something new, I don't know, but all of my patients are teaching me, and then I'm sort of regurgitating that and providing it for other healthcare practitioners, nurses, medical doctors, naturopathic doctors, alike, who would be involved in vaccination too. So be aware of this. If there is a better way of doing this, then there should be a better way of doing this. There's nothing wrong with that. There's nothing wrong with improving the way we're doing things.
I think that's awesome. And I think so many people who are listening to this are going to want to work with you, but unfortunately that is not possible if they don't live near you or in
Right.
BC, right? So,
Well, I should say that I do support families around the globe, because when it comes to vaccines, pretty much it's just us having a conversation. There's really no treatment that's occurring. And if you have a naturopathic doctor or medical doctor that I can work with, nurse practitioner, bonus. But a lot of times it's just questions like, can we split the MMR vaccine? Or, my child is 2 and I want to start vaccinating. Which one should I start with? And so that's where a
so
lot of
you do
times,
consultations for
yes,
folks
yes, I do
anywhere.
tons of
Okay.
consultations that way, because it's just, we're having a conversation and demystifying certain things, or educating them on something, or giving them a direction of what to read and learn more of.
Okay.
And then
You
if it
wouldn't be
goes,
giving protocols during
no,
those
no,
if
I
they're
wouldn't be
not in
doing,
your licensing
right.
jurisdiction. Okay.
Right, exactly. It wouldn't be detailed. Now, if you have a naturopathic doctor that you're working with, I send them the protocol, and then I give them the suggestions of what they should use for you. So come with someone that you're working with. Makes this process so much easier, because I'll answer all of your questions, and you go back to your naturopathic doctor. Because when naturopathic doctors within this country, very limited in terms of what they can say and do around vaccines, because they don't administer
Yes.
vaccines. Only in British Columbia can naturopathic doctors administer vaccines. And then there's also not many of us that do it. So, so then I'm working with families, and then they go on to work with their naturopathic doctor, which isn't doing anything around vaccines. We're just supporting the body, and be it through evidence around probiotics increases efficacy of vaccines. Tylenol decreases. Glutathione would be helpful as well. So vitamin D would be helpful as well. So these things as well. What dosage do you use? Well, that is something you need to have a conversation with your practitioner, because the age of your child is different. Maybe you're breastfeeding, maybe you're not breastfeeding. So all of these little nuances change as a result.
Yes.
But yeah.
Okay, amazing. And you have a 3-part web class that is currently available as well for folks if they want to learn more. Can you share more about where people can go to maybe
Sure.
work with you or get more
Sure.
information about you?
Yeah, the easiest place would be my website, which is www.drtaylorbean.com.
And I'll link to that in the show notes as well for everyone.
Excellent. Yeah. And so on that then homepage, as soon as you scroll down, I do have where I have my top 5 vaccine questions that people ask me is there, and you can put your email in to get that access to that. Just below that is going to be the recordings of my 3-part vaccine webinars that I did in August here in 2020. And the first one is about infant immunity. I think we should have a better understanding of how infant immunity works, because that's very important, how it develops. And this information is coming from immunologists. I'm using their information. I talk a little bit about pregnancy. And then the second webinar is on the infections themselves. I don't talk about influenza because it's not really part of the child vaccine schedule, although it's starting to sort of be more common. But I talk about every single one individually. So that one's, you might want to take a break halfway through and come back to it, because there's a lot of information there. You might want to pause. That's what's great about recordings. You can pause, you can look at the screen, and you can see how, if it's a bacteria or if it's a virus, and what's the name of it and what are the symptoms. And so I think that's important to know. And the reason that I talk about the infections is because you can have been vaccinated and you still may contract the infection. Vaccines are not 100% effective, and no one will say that they are. They'll say they're effective, certainly, but not 100%. So there is a variability potential of your child contracting the infection, and then knowing how long the antibodies potentially lasts for. Some are longer than others. So then that would mean either you're doing more often that vaccine or less often of the vaccine due to updates of how long immunity lasts for. So that part I'll talk about. And then the third webinar, which is probably, I think, the longest one. It's about 2 hours. So do it in chunks. It is about optimization. It's about levitating the health of our children, period, regardless of vaccines and what that means, gut function, environmental toxins, where you come in more so of people need to work with you in terms of really dialing into what environmental toxins mean and where we get access to them. So I do a little bit about that. And then them getting into vaccine optimization and what does that mean and what does that hold, and so why I use the things that I use. So I talk specifically why I use vitamin D or vitamin C or glutathione and these kind of things, so then you can have that information as well. This isn't just a idea that I put together all of a sudden out of thin air. No, this comes with, I have my reasons of why I use those things and share that with people.
And
No, there's no.
I took the class back when you did it live, and it is great. And Taylor does not dumb it down. Like, if you follow me, you're probably into the science and like to geek out a little bit. This takes like the geek out to a whole new level. So definitely go into it with that kind of student mindset. But it was such eye-opening.
Thank you.
Eye-opening course. So
And
I highly recommend that you guys check that out.
thank you. I mean, that's the complaint. I will be honest. The complaint is that it is more technical. And the reason I do that in my explanation, which I think I did in the first one, was, yeah, I can be down here with the information. I don't have to push you, or I want you to be elite, VIP, understanding, and I can take you up here. You have the information, you have the dialogue, you got the actual names of things. I want to push people to be Olympic athletes. This isn't just for fun and, I don't know where you are in your journey, but I want you to be up there. So I'll push you to be up there. So either you have to listen over and over again, fine, but I'm going to push you to the limit because I want excellence in people. I want excellence in me. And as I learn, I'm going to share that with you. And so, because we're at this point now of, we're capable of getting there. We're capable of understanding. And almost some of that onus is put on you to understand it now too. And so to have that verbiage, to have that grammar, to have those words, and it's not so that you're going to turn around and go to your medical doctor and be so confrontational with names and push them and see. I want you to just understand, that's it. And if you get within a conversation with people, then you have that information that if you have to go there, you're capable of going there. Maybe you don't ever have to go there with the dialogue you have with people, but why not? Why not achieve the best? Why not? So
I love it. And I think it's at this point, and this is what I'm all about as well, is it's health literacy and getting back to understanding the decisions that we're making and how we're going about our day to day and really taking back ownership of those decisions. And I think we kind of veered off course for a while. And I love that you help people gain that confidence and competence to understand a bit more about their bodies and the decisions they're making. So thank you so much, Dr. Bean, for the work that you do. This has been an amazing conversation, and definitely check out the links that I will pop in the show notes for all of the resources that Dr. Bean mentioned today. And yeah, that's it. Thank you so much.
Well, thank you for having me. This is brilliant. And even our relationship now has been wonderful for me to get to know you and the work that you're doing, because I'm like your biggest fan. So
thank you.
I want to learn more about, environment and what's in it. And so thank you, because this has been great. So me getting to know you and this and whatnot, but thank you for having me on. I appreciate it.
I love it. Bye.
Bye.